Okay, so I'm up next. Just get my first slide. Yeah, so timing of surgery in mitral regurgitation is a consistent theme that comes up regularly at the society meeting, and I know in a lot of the cardiology meetings. And so I'm going to spend the next 10 to 15 minutes or so giving you my perspective and looking at some of the literature that I have reviewed during my time in practice. So I'm going to stick to degenerative mitral regurgitation, where it's primarily a valve problem. I'm not going to talk about functional disease. So I'll start off really by asking a question about a patient really to the surgeons in the room. Imagine you've got this patient, he's 76, he's asymptomatic, he can play 18 holes of golf, but his GP has found a murmur on clinical examination. On his echo, it shows severe mitral regurgitation. It's a P2 prolapse, but his LV is normal in terms of size and function. Just from the surgeons in the room right now, I've asked this question before to an international audience. I'm just interested to know from the UK cohort we've got, how many of you would offer him an operation?
Does he walk the course or is he that's very different.
Yeah, he walks the course. Okay? None of you? Okay, that's interesting. All right, good. Let me take you to just another little bit of data then. So basically what we're talking about here is, do we do surgery or do we wait until he reaches the indications that, the strict indications that Rachel talked about. So there's an app called the SCTS iData app, and if you plug in a 76-year-old male, isolated mitral repair, no other major risk factors. From the, I think in the 4 years between 2008 2012, there were nearly 200 entries for this scenario, and the operative mortality was less than 1%. So we know that in the UK, this gentleman would get a mitral repair with a very low mortality. So let me just take you back to basics. I remember I had an opportunity to spend dinner with Ottavio Alfieri about 3 years ago. And I took this with me this is what our conversation revolved around when I was finishing my training. And it's something that he's incorporated into the guidelines. This is my approach in clinic now. So I look at how severe the mitral regurgitation is. Are they symptomatic? Do I think the symptoms relate to the valve lesion? What is their life expectancy and expected quality of life? Do the expected benefits outweigh the natural history and the risks? What does the patient want, and what is the local expertise? Could I provide a durable repair, and would it be at a low mortality? So these are, as Rachel discussed, these are my two main guides for determining whether or not I offer surgery to patients referred in clinic, but there are small differences between them. I know Rachel's just covered this, but as a very broad overview, the primary indications, the class 1 indications are if they've got severe mitral regurgitation and are symptomatic. If they're asymptomatic, then there's 3 trigger points that I look for, and that is LV dysfunction, pulmonary hypertension, and atrial fibrillation. However, things are moving, and the AHA guidelines have changed between the previous one and the new guidelines. So for this man who has severe mitral regurgitation, is asymptomatic, and has a normal LV, he would fall into the class 2A indication for the AHA guideline, as long as I have a 95% expected chance of repair and the chance of mortality is less than 1%. ESC is a little bit different. It's still a little bit more conservative. If they have severe MR, no symptoms, and a normal LV, so less than 40 millimeters end systolic dimension, they need to have other features. And those two other features that is talked about in the ESC guidelines are exercise pulmonary hypertension or LA dilatation. So I think we've all got a common goal. We all want to, whether it's the cardiologist or the surgeon and the patient, everybody wants to do the same thing. We want to keep that patient's quality of life, have a good survival, preserve the LV function, and have a successful mitral repair. So what I want to try and do is take you through, just remind you of things that I know you already know, but take you through the natural history and also look at what actually happens when you reach those trigger points recommended by the guidelines and how they influence the surgical outcome. So let's look at natural history data. There's been a number of studies in the last few years looking at the watchful waiting strategy. The mortality rate per year following the watchful waiting strategy is very different amongst all the studies, ranging from 0% to 8%. You'll notice that the ones which have a lower mortality rate per year definitely have a younger population that they're looking at. And in addition, if we take the Rosenheck paper, which is commonly quoted, it has a 0% mortality rate per year, very well followed up. You'll notice that in series like this, where there is a very good outcome from a watchful waiting strategy, it's the investigator that's doing the following up, not the referring cardiologist. So they really keep hold of their patients and watch them very closely. If you plot all of these studies on the same graph, you'll see that people with asymptomatic severe mitral regurgitation, 50% reach a trigger point within 5 years. So you do need to watch them closely. And this is corroborated by data from Enrico Serrano that the worse the mitral regurgitation is, the worse the survival. So if you look at asymptomatic severe MR with a flail leaflet, it is not an indolent disease. Although it's not as bad as severe aortic stenosis, there is a sudden death rate associated with it. And even in people with NYHA 1, there's between a 1 and 1.5% death rate per year associated with a flail leaflet. And this goes up if you let the LV start to deteriorate. So I'm just going to go now just to talk briefly about what happens when those 3 trigger points are reached. LV impairment, pulmonary artery pressure increase, and AF, in those patients that do eventually come for surgery. So I'll just take you to the left-hand graph. If you just look at the bottom line there, these are people with a reasonable LV, but with symptoms, compared to those with very little symptoms. And you can see that if you operate on people, once they have florid symptoms, even after surgery, they do not go back to their normal survival curve, unlike aortic stenosis. They are on a lower survival curve compared to those who have minimal symptoms. And that gap widens once their LV starts to become impaired. If you look at LV impairment, that was the other criteria. The top line is if they're referred with a good LV. Once their LV starts to deteriorate at the point of surgery, their 10-year outcome can be as much as 20% difference in survival. This is a slide I first saw at the conclave from Tyrone David's group just 2 years ago. And he demonstrated that even between NYHA, even if you get a patient and you operate on them, and they're in NYHA 1 compared to NYHA 2, at 20 years there will be a difference in their survival. And I think when you see people in clinic, these are usually elderly, usually overweight, they're deconditioned. It's difficult to pick up that point where they go beyond these boundaries from NYHA to NYHA2. And a lot of the time in the UK, these patients are being followed up and seen by the registrars and being followed up at 6-monthly intervals. They can be easily missed, I think, that's what I'm saying. Let's look at atrial fibrillation. At 10 years, if your patient is in atrial fibrillation compared to sinus rhythm, there'll be a 15% difference in survival, depending on the point of referral. And that difference is even more marked and is apparent at 3 years if they have pulmonary hypertension. Now, if you look at the STS data, mitral valve repair is on the increase, which is a good thing. We all recognize that it improves survival compared to replacement. It maintains LV geometry. You avoid anticoagulation. It's also on the increase in the UK. It's a technique which is now established, and more surgeons are being trained in these specialist techniques. Mitral valve replacement is on the decrease. And mortality, if you look between 2006 and 2012, was below 2% across the board for isolated mitral valve repair. From Tyrone David's data, which we know is surgery in the best hands, 20-year freedom from thromboembolism is excellent, and freedom from reoperation is approximately 10% at 20 years. Now, there's new technologies coming in, and we've got a couple of speakers this afternoon talking about that. But now that minimal access technology is here and is being offered in more and more centres, younger patients can be offered these techniques, avoiding a sternotomy, enabling them to return to activity quicker, and preserving the front of the chest if they ever do need a redo procedure in 20 years' time. There is data out there showing that referral patterns are still quite late in the US, and I'm sure that we've all seen patients who could have been referred earlier, and I think it's an important message to get out. So the outcomes are determined by the patient's condition, the point of referral by the cardiologist, and the expertise of the surgeon. And I think at the minute, the weight of evidence does favour early surgery. The change in the AHA guidelines in 2014 have reflected that, and I'm pretty sure the ESC revision guideline will follow suit. There are other triggers. We're investigating BNP and volumes, as Rachel has mentioned. And there's also a UK early mitral trial looking at patients with normal LVs who have asymptomatic severe MR. This will be the first randomized trial in this, and hopefully should provide some additional data to support what we suspect is the right thing to do. Thanks very much.